Okay, so let me just get back here. So I'm going to introduce Dr. Maitreyi Raman. She's a gastroenterologist, a physician nutrition specialist, and an associate professor of medicine in the Department of Medicine and Division of Gastroenterology at the University of Calgary. She's also a co-founder of LyfeMD, and she has clinical and research interests in lifestyle as a primary therapy for patients with digestive diseases, and investigates the role of diet to modulate the gut microbiome and chronic inflammation in inflammatory bowel diseases and irritable bowel syndrome. In addition, Dr. Raman explores the role of the gut-brain axis through mind-body interventions and its impact on chronic disease outcomes. So please welcome Dr. Raman, someone I feel very lucky to be able to work with. So I'll stop sharing here and we can get your slides up there. Okay.
Okay, so can you see my slides?
Yes.
Okay, perfect. Well, thank you very much, Jackie, for the great introduction and the introduction of the topic. And it's really my pleasure to be able to talk to you all today about some central mechanisms in irritable bowel syndrome management. So these are my disclosures. And so Jackie has very nicely laid out the overall program objectives, but over the course of the next 20 to 25 minutes, I specifically will plan to take you through the role of the brain and its various networks in the onset and pathogenesis of irritable bowel syndrome, and then discuss some mind-body interventions and their impact in IBS management, and propose some reasons why, or the mechanisms, the central mechanisms for the effects of mind-body interventions and how they influence IBS outcomes. So first, in terms of its impact, the prevalence of IBS is tremendous, affecting between 12 to 20% of North Americans, of which 50% of people will seek IBS seek medical advice from their physicians. And in fact, this can be a very devastating and frustrating disease in that patients on average require 9 visits to their primary care physician before a diagnosis is offered. And it accounts for up to 50% of consultations to gastroenterologists. Patients with IBS experience more hospitalizations, more emergency room visits compared to non-IBS patients, and incur 2 to 3 times as many operations, such as hysterectomies, cholecystectomies, or appendectomies than non-IBS patients. And it can result in a significant loss of productivity between 9 to 22 days off work annually, and result ultimately in poorer quality of life, with up to 14% of patients willing to accept a 1 in 1,000 chance of death or a serious side effect from a medication in an attempt to achieve perfect health. Now, historically, IBS has been defined as a functional bowel disorder, but more recently, it has been recognized as a disorder of the gut-brain interaction. And the reasons why it occurs, or the pathophysiology of IBS, is truly multifactorial. There's no one reason why symptoms of IBS manage. And because the mechanisms of disease are so poorly understood, it translates into significant difficulty to manage it clinically. And there indeed are limitations of medical management, to the point that numerous licensed and unlicensed medications have been tested in randomized controlled trials. But for the most part, most of these medications are of similar efficacy. And this leads, unfortunately, to many patients who are refractory to medical management, and up to 50% of patients with IBS seek complementary or alternative medical approaches. Now, in terms of the advancements in the science between the brain-gut and the gut-brain axis, we see that there are indeed several. So if you look on this complex figure on we see the brain positioned at the top of this diagram with the bowels focused lower down. And if you look at the directionality of the various arrows, you see that the brain can impact numerous functions. the emotions that one feels, the pain, the emotions, the cognitions, the thoughts, the social behaviors, all can independently affect the autonomic nervous system. And in doing so, it can strongly affect the gut motility as well as gut secretions. Now, in addition, the brain can affect through the hypothalamus and pituitary axis and the sympathetic nervous system. It can independently affect immunity. And this immune dysregulation or regulation may in turn affect the motility of the bowel. Now, if you look at it from a bottom-up approach, we see that the food one eats, the diet, the pathogens, the infections people may be exposed to, the antibodies they may mount, in turn, these may influence the microbiome as well as the microbial metabolites, and ultimately the gut microbiome may independently affect the brain in terms of the mood, in terms of the sensation of pain, as well as the overall well-being of one's holistic self. And then here you throw in some stress, some early life adversity, minimal social supports, or inability to access medical health care. We see that this can also compound how the perception of pain is regulated. So we can see that indeed the brain-gut axis and the physiology of this is indeed complex. And when you come over here and you look at the diagram on the right-hand side of your screen, here we can see that there are two pathways. There are pathways that signal from the actual enterocyte or the small bowel cell. And if you disrupt this cell because of poor diet or other particular factors, including gut infections, it can stimulate the autonomic nervous system in a way that can signal aberrantly to the brain. And similarly, the brain can signal aberrantly to the gut, influencing how the gut functions. But when we look at this and we think about how we typically manage IBS, we see a lot of prescription medications used that have nothing really to do with any of these potential pathophysiologic mechanisms and ultimately only treat symptoms. So therefore, there's a major gap in terms of how IBS is presently managed. Now, here I'd like to highlight that not only are there structural brain, there are also connective or connectome differences in how the brain functions. Various brain networks have been described, including these that are seen on this screen. We see, for example, the central executive network, which is highlighted on the top left-hand of your screen, is one that is responsible for making decisions. So when good decisions are made or perhaps poor decisions are made, we see that in part this is influenced by the connectivity of the central executive network. Now, in the middle of your screen, you see the salience network, which is one that is responsible for influencing how one focuses their attention. So if an individual experiences pain and they focus on that pain to the exclusion of any other number of things that may be going well in their life, the salience network is one that's responsible for shifting and focusing attention. Now, in contrast, if you look at the bottom left of your screen, the emotional arousal network, this is a network whereby individuals may influence, or the connectivity of this network influences how an individual feels emotions, perceives specific activities or events that may ultimately influence how they feel and how they respond to those feelings. So it's been demonstrated that a variety of these various networks, which you can't see, but have been demonstrated to signal to each other in aberrant pathways, occur when diagnosed with IBS compared to healthy controls. So clinical symptoms that result from these various brain network disruptions include chronic abdominal pain, anxiety, poor coping skills, as well as altered bowel habits. So this leads to the potential possibility for a futuristic vision whereby not only is a diagnosis of IBS made through symptoms and excluding other criteria, obtaining brain imaging data may in fact provide us with some input as to which potential mechanisms or connectomes may have disruption, and also may lead towards specific interventions, particularly mind-body interventions that may help improve the course of disease. Now, IBS is believed to be associated with an exaggerated cerebral response, including emotional processing. So in this neat study involving 20 male IBS patients who were age matched to healthy controls, these individuals had a balloon inserted into the rectum with various pressures increasing incrementally over time. All of these individuals had functional MRI testing completed both before the rectal balloon test as well as thereafter. And here I'd like to call your attention to the pictorials on the right-hand side of your screen. And we see patients with IBS in the purple on the left and healthy controls on the right. And what you see is that with rectal balloon distension, various different areas in the brain light up or don't light up when diagnosed with IBS compared to healthy controls, suggesting that when we think of these functional connectomes, differential activation was seen in the brain in different brain regions in IBS patients, controlling motivation, homeostatic emotions, and autonomic responses to pain. Again, providing some proof of concept that alteration in these connectivities or connectomes is present when diagnosed with IBS. So with all of that in mind, what do we typically do in terms of IBS management when we have a patient in front of us practically? So numerous national guidelines for the management of IBS all throughout the world recommend that psychological therapies should be considered. And there are a variety of different psychological therapies for which there is evidence, but the relative efficacy for each of these psychological interventions remains unknown, largely because there have been very few head-to-head trials comparing psychological interventions to other interventions or even to other psychological interventions. So one recent systematic review and network meta-analysis, including 41 eligible randomized controlled trials and approaching 4,100 participants, was undertaken. And here they reviewed a wide variety of psychological interventions, cognitive behavioral therapy being one of the more frequent utilized therapies. And I'm sure this audience is extremely familiar with CBT therapy, but just as a quick reminder, CBT includes both behavioral and cognitive interventions, which are typically short-term and skills-focused, which ultimately aim to decrease maladaptive behaviors as well as maladaptive cognitions and implement interventions to ultimately modify emotions such as fear, anxiety, anger, and other emotions that can adversely affect the course of IBS. Now, in this meta-analysis of approaching 4,100 patients, you see that there are a wide variety of psychological therapies highlighted on the left-hand side of your screen, ranging from interventions such as contingency management, group CBT, CBT via the telephone, and you can look down the list. You'll see some items such as hypnotherapy, CBT via the internet, mindfulness meditation, etc. Now, when you look at the forest plot in the center of your screen, you see that anything that is on the left-hand side of your screen favors the experimental therapy versus anything on the right-hand side favoring the waitlist control or the individual that didn't receive the mindfulness intervention. And here you overwhelmingly see that in these 4,100 patients, after they engage in most of these behavioral or psychological interventions, that in fact, most psychological interventions do very well, strongly favoring improved outcomes when exposed to the psychological therapy compared to not being exposed to the psychological therapy. Now, this is at the first point of follow-up for most of these studies. Now, if we specifically look at people who are included in this meta-analysis that have had exposure to other therapies, so they've been refractory to commonly used other IBS medications or IBS interventions, we see here that the mind-body interventions or the psychological therapies improve even further. So they perform even better after an individual has been refractory to other IBS therapies. And then even interestingly, if we look ahead, so what happens after a long-term follow-up point? So let's say 6 months, we see that CBT and other psychological interventions continue to perform even better with greater distances or time out from the original enrollment in the studies. So the authors of this manuscript concluded that several psychological therapies are more efficacious than control interventions, but no one psychological therapy was superior to the others, with future directions for research-minded individuals to consider high-quality future randomized control trials with appropriate control groups that extend beyond waitlist controls or usual care control interventions. Now, what's really neat for me, at least, there's been very much a limitation in the data or a paucity of literature around why CBT actually works. And although nothing has really been published in the field of IBS, if we look at other conditions like trauma, for example, CBT has been well explored in the trauma literature and some interesting findings have been observed. So when CBT and eye movement desensitization regulation therapy, another form of a mind-body intervention, are applied in patients who have previously had trauma, they see that, again, there are significant improvements clinically when utilizing the gold standard self-report survey. So the gold standard tool when thinking about post-traumatic stress disorder is a clinical tool called the clinician-administered PTSD scale. And what they identify here is that when individuals have been exposed to CBT or eye movement desensitization therapy, and they have significant improvements in the primary outcome, which is the clinician-administered PTSD scale, we see significant improvements again in these brain connectomes that are involved in IBS. So anything in blue represents decreased connectivity, anything in red represents increased connectivity, and we see that CBT, in fact, improves the connection between various areas in the brain or in these connectomes that have a role to play in regulation of a number of different factors. So what about other mind-body interventions? So I've shown you a lot of information around cognitive behavioral therapy, but still it's really infrequently utilized. And this can be, the case for many different reasons, including the availability of therapists, the costs of therapists, potentially the stigma of therapists, and accessing care. And if we look at other brain-gut interventions, yoga, breathing, and mindfulness being yet another mind-body intervention option, we see similar trends start to exist for the findings of implementation of yoga, similar to what we see for CBT. Now, when we think of yoga, typically we think about physical postures, we think about controlled breathing exercises and/or mindfulness or meditation interventions. But the practice of yoga has its roots in ancient times, with practice and data extending well over 1,000 years of practice. And it does include other components that lie outside of the postures, breathing, and meditation. But when we think of the practice of yoga from a medical perspective, these are the three intervention points that have received a lot of attention. And we see that the practice of yoga has a significant impact, again, on the autonomic nervous system, on the liberation of these neurotransmitters highlighted in the center of your screen, including dopamine, serotonin, acetylcholine, GABA, etc. And it's thought that these neurotransmitters are, in fact, what is responsible for facilitating the connectivity in these various brain connectomes. The practice of yoga also has had an impact on improving or enhancing specific neurotropic factors. Well known would be a factor called BDNF, as well as enhancing the immune system. Ultimately, clinically, the practice of yoga can lead to a variety of outcomes, including improvements in depression, anxiety, negative symptoms, cognition, sleep, as well as attention. Now, what about specifically to IBS? So I'd like to share with you a manuscript that we recently had published in the American Journal of Gastroenterology, resulting from work that my PhD student, Dr. Adriana De Silva, recently completed as part of her time with me at the University of Calgary. And here she recruited approaching 79 patients who were diagnosed with IBS and randomized them to receive either a virtual yoga intervention or educational materials. And this yoga intervention included an 8-week program whereby individuals were asked to attend a weekly virtual class and then practice at home on a daily basis. Over the course of the week, the 8 weeks, they learned physical postures in week 1, alternate nostril breathing in week 2, mantra-based meditations in week 3, breath watching in week 4, and then combined practice weeks 5 to 8. And to be included in this study, one required a diagnosis of IBS using gold standard criteria, namely the Rome-4 criteria, required to be between the ages of 18 to 70 and have at least mild symptoms of IBS as diagnosed by a score of 75 on the IBS symptoms scale. They required stable medications as well as stable diet and physical activity prior to coming into the study, and they were excluded if they had really any major physical or cognitive impairment. Now, this is a busy slide, but I'd like to walk you through some of the results. Now, here we see data for the treatment group on the far left and the control group on the right. And the primary outcome was change in the IBS symptom severity score. And we see that there was a significant improvement in IBS symptoms in the yoga treatment group, which was not observed in the control group. Moreover, and perhaps even impressively so, we saw significant improvements in quality of life within the treatment group, but not in the control group, which was significant between groups at the end of this study. Now, interestingly, many patients coming into the study only had mild depression, if any depression at all. And while this was not a significant difference in depression, it was of clinical relevance whereby we saw a trend towards improvement towards symptoms of depression in the treatment group, as well as between groups. And we also saw significant improvements in fatigue within groups and between groups, as well as COVID-19 stress, with a trend towards significant improvement in perceived stress overall within groups, which also persisted between groups. So overall, overwhelmingly positive results from this yoga trial. Now, what we found was that on average, most patients, approaching 80% of patients, attended class at all time points. And the treatment participants accumulated an average of 1,221 minutes during doing yoga during the course of the study, which really averaged to 21 minutes of practice per day. So now, what is known about meditation and yoga and breath work and the effects upon the brain connectivity? So I was interested to find this study whereby these investigators explored the effects of an 8-day intensive meditation program on brain connectivity. This was a small study where they included 13 participants and 4 controls who underwent functional MRI before and after an 8-day residential meditation program. And here they again identified significant differences and improvement in functional connectivity between these various networks, the salience network and the default mode network. So the network that helps you understand where to focus your attention and how to be in the present moment and to make decisions that are executively the right decisions to make at that point in time. And interestingly, changes in mindfulness scores were correlated with changes in functional connectivity as well. Again, lending support to the fact that mind-body interventions can not only affect the structure of the brain, but also the function of the brain. And this study or this slide summarizes the various impacts of yoga as well as breathing and mindfulness on these various components of the central nervous system. Yoga practice can improve and increase cerebral blood flow. It can increase protective neurohumoral factors like GABA, ultimately increasing neural activation, prefrontal lobe activation, decreasing stress, improving gray matter density and volume, and ultimately these changes in gray matter morphology can improve neuroplasticity and ultimately IBS symptoms as well as holistic wellness. So with that in mind, as I've alluded to earlier, accessing mind-body interventions historically has been somewhat challenging due to a number of different factors. So in part, the LyfeMD application was developed to support patients not just with digestive diseases, but certainly very relevant to digestive diseases, because many of these conditions not only have a significant mind-body role to play, but also have a significant diet and nutritional component that influence the course of disease. And the LyfeMD application includes signature and personalized dietary interventions, as well as yoga, breathing, mindfulness, and physical activity interventions to support patients with a wide variety of therapeutic indications listed on your slide on the far left, including IBS. And then in the next part of this presentation, Dr. Taylor will review the application and how it may be utilized to help manage your patients with digestive conditions. Now, really quickly, I'd like to highlight this slide for you. This is just one screenshot of many in the LyfeMD application. Here, patients will complete a variety of questionnaires when they onboard into the application, and they will receive some scores that inform on their sleep quality, their depression, mood, anxiety, as well as other potential factors which may influence their IBS. And then based on how they score, they will be recommended specific programs, whether it be a short 5-minute program they can do in the morning prior to getting their kids ready to school, or an hour-long program that may be required prior to bed to improve, or prior to bedtime to improve their sleep quality. And Lorian will speak to these programs in more detail shortly. Now, really quickly, I'd like to highlight the fact that we have several users on the LyfeMD platform now, approaching almost 1,000 users. And we see that patients come onto the LyfeMD application because they experience moderate to severe stress. About 70% of patients, this is the case. Almost 100% of users experience sleep problems. They may experience moderate to severe anxiety. They may also have moderate to severe depression scores. Many individuals are overweight, and most do not meet their physical activity goals. But after spending some time utilizing the LyfeMD programs, these are data coming from a randomized controlled trial, so the highest quality evidence that can report on the effectiveness of interventions. We see that there is significant improvement in diet quality in those individuals that utilize the LyfeMD application compared to those that don't. There's also significant improvement in time spent in physical activity, as well as in overall well-being. And finally, we see there's significant improvement in sleep, as well as a more significant reduction in anxiety in individuals that use the LyfeMD app compared to those that don't. So in conclusion, I'd like to highlight that holistic lifestyle programs are indeed effective to improve several symptoms of relevance to the patient with IBS, and that mechanisms for the effectiveness of mind-body interventions are being discovered. And the more we learn, the more we understand how important the mind and body connection, or the mind and gut connection, is to improving not just symptoms, but overall changing the course of disease. And that digital tools that are scalable may be utilized to provide care alongside usual treatments. So with that, I'd really like to thank you for listening today, and I'm happy to turn it over to our moderator, Jackie.
All right, thank you so much. So that was hopefully helped, everyone improve their knowledge of the benefits of the mind-body interventions and just get right into the science of it. So that was great. I'm just going to share my screen here. Give me one moment, and then I will do our poll again briefly, just to see if anyone, well, you know what? I'm actually going to change course here. Stop for a sec. I'm going to go back and we're going to do the poll afterwards. I've changed my mind because I think once we go through some parts with Lorian, it might be more beneficial. Okay, so let me just go to our next slide where I'm going to introduce Dr. Lorian Taylor. Dr. Lorian Taylor is the CEO of LyfeMD, a digital health platform And Dr. Raman did introduce some of it already, but basically it has anti-inflammatory diets, lifestyle therapies to people with digestive diseases and those who want to maximize their gut microbiome health. Lorraine is a registered dietitian and has worked as a research scientist at the University of Calgary in the Department of Medicine. In the course of her PhD and as a research director, she has published over 40 scientific papers exploring the role of nutrition and physical activity on health. Dr. Taylor has spent the last 10 years developing and leading effective nutrition and physical activity interventions, and the focus of her research is to help change lives by promoting health in both the body and mind. Please welcome Lorian, who will bring us behind the scenes of LyfeMD to learn more about the IBS programming currently on hand and shed some light on the tools, how to use them, and the various supports such as dietitians, therapists, kinesiologists, health coaches that support the tools and programming. Another person I'm very proud to be working with. So I'm going to stop sharing my slides here, and Lorian, you can take it away.
Thanks, Jackie. That was such a kind introduction. I'm just going to, what I'm planning to do today is walk you through the LyfeMD app. So I want to show you how it works, what programs are included in it, and so that you would feel more comfortable using it or talking about it with your patients. And then I'm also going to walk you through at the end, how do you, if you want to use LyfeMD, does it cost anything? How do you use it with patients? And then next steps if you want to use LyfeMD with patients. So the screen so LyfeMD is available using either a web application or your phone or iPad. So this is, what I'm displaying here is the actual web application. So people can sign up and use their computers. And this is the IBS program specifically. So we have, as you saw in that slide that Dr. Raman presented, you can choose an IBS program and then get IBS specific content. So I'm going to show you first the eating plan. Now, many of you on the line are familiar with the low FODMAP diet, so I'm not going to talk about it. Many of you probably know even more about it than I do because you've taught it to patients numerous times. So what I want to demonstrate, though, is how we've incorporated a low FODMAP diet into the LyfeMD program. So every patient who comes into the program will be asked to complete an IBS clinically validated tool that they are then asked to report their symptoms over time. So I am going to just quickly show you how this fills out. And then what happens is patients are given a score. So you remember in the beginning, Dr. Raman mentioned for the trial, anyone with a score of 75 out of 500 was considered to be mildly symptomatic. So this is the same scale used in the app. And you can see here, I've scored about a 342 out of 500, meaning that I'm quite symptomatic. So then I am able to choose options. So these options include a few different things. So we have our IBS diet, phase 1, phase 2, phase 3, as well as a low FODMAP, phase 1, phase 2, phase 3. So what these different diets demonstrate is one of the diets with the low FODMAP eliminates many of the foods that have FODMAPs, and then you have a stage of then reintroduction to the diet. So I'm going to show you, I'm going to select low FODMAP phase 1. And it walks people through the diet. It gives them information on how it works, gives them a bit of context in terms of what are FODMAPs, and then gets them started. So what people are able to do here is they're able to go back and forth to information stages. They learn about elimination. They also are asked if they need support from a coach at that time to ask questions. They're able to do that. And then what they're doing is they're guided through, these are the foods you should eliminate. And then they're encouraged to track those foods every day of the week. So you can see here and all of the unlimited vegetables are listed in the information screen. I just didn't want to go through that today with you. So they're given information about all of those things. They track them over time. And then they are able to see if foods are if this diet for them is working or not. When they're able to, if they say, for example, okay, yeah, I had some limited vegetables and I noticed an increase in my symptoms, then you know as well as practitioners, okay, some of these vegetables are probably causing problems. We need to encourage elimination of all limited vegetables so we can actually figure out what is causing a problem here. So that's how the low FODMAP phase works. And then what people are able to do is they're able to actually begin to reintroduce foods. So I want to show you what that looks like. So this FODMAP phase also goes through reintroduction of foods, talks about the stacking effect, gives them guidelines on how to avoid the stacking effect, and then they're able to start the diet. Now, what I really like about this as a dietitian is how it walks people through the stages of elimination. So as a dietitian, I frequently struggled with how much should I tell people to introduce? How should they do it? And then coming up with pretty complicated plans for people around how to reintroduce foods. So what we've done as part of this is created a food trial option. So for example, I'm going to reintroduce some cauliflower that's green and raw into my diet. So I'm going to pick that. And then you go down below, and I want to eat maybe a cup of cauliflower. So I'm going to pick one and I'm going to pick cup. So what I like about this is that it lets people say, okay, I probably am not going to eat more than a cup of cauliflower at a time. Maybe I just want to eat half a cup. How do I figure out if this is going to bug me? So what the app does is it divides it into quantities that people can then test over a series of food trials over 3 days. They fill out every day of the food trial, they fill out their symptoms that they're experiencing. They can make notes about those symptoms that are then later recorded for them to go back to. And then they are able to track everything that they have done over that time and those symptoms again. And all of those symptoms then get recorded. And then they are given context around, okay, when I ate 0.3 of a cup, I did have some symptoms, same thing with half a cup, but then, oh boy, when I had 1 cup of that food, I really did have symptoms. Then they're able to walk through a series of other questions. So did you use the stacking effect? Were you experiencing any difficult emotions? Did you follow some good mealtime practices? And then once they complete that, I didn't click it as I went through. They're then able to talk about, ask them a few other questions about their mindset, and then what do they want to do? Do they want to avoid this food for now, or do they want to try and include this in their regular diet? So I'm going to say avoid this food for now, and I'm going to finish my trial. Now, what's nice about this is then it goes into a My Foods list that includes all of the different foods I've tried to try to reintroduce, tells me, okay, these are some of the symptoms that I had while I was experiencing them and the amount that I had symptoms at. And that's the eating plan for the LyfeMD program. And you're able to work with your patients as they work through this program as well. Dr. Raman did show you what the yoga, breathing, and mindfulness plan looks like. I do just want to highlight here, there's different programs for sleep, stress, well-being is a combination of depression and anxiety. So people who have a poor well-being score will have higher levels of depression and anxiety. So let's say I want to improve my sleep. I get to choose between what kind of programs I want. I'm going to choose both. Then I also get to choose from programs some that take 5 minutes and some that take 60 minutes. So this is a very good way to get people who are new to this practice to be able to try this out for themselves. I'm just going to go back here. I'm able to choose the days that I want to practice. And then my yoga program is updated with the new program that I've chosen. You can watch the video is right in the app, and you can watch it on your computer or on your iPad or your phone and follow along. The movements are listed here, and then the meditations are audio files that are listed below. And you'll notice every different program includes those 3 factors. So we've included movements, We've included breathing activities, and we've also included meditation if people choose to do both activities. And then people are then able to track the days that they do those activities. For the physical activity plan, we provide both beginner and advanced workouts depending on the amount of activity that people are already doing in their day. These are all graded activity movements. So this video isn't an actual video that they can follow, but it demonstrates 4 different phases of an activity. So for example, my 70-year-old mom couldn't do a goblet squat. So what the video actually demonstrates is, okay, first it's getting in and up out of a chair until you feel comfortable. Then it's a bum tap. Then it's without weight. And then you work your way up to a weighted squat, for example. So it takes people with where they're at and tries to provide programs to them that meet them there and are able to sequentially build over time. Now, I think you might also find this interesting. So we have a tab called My Behavior Change Tools. What this includes is it includes 3 different types of activities. So we have a 16 activity complete cognitive behavior therapy program that patients are able to do on their own or even with you in appointments, or they're also able to access our coaches who can help guide them through and support them through this program. As they work through, it's designed to be completed weekly, and then they do homework, and then they can come back to whoever they have identified as their support person to help them do this, or they're also able to do it on their own. The other behavior change tools I think you might also find very interesting. Remember, in some of those environmental determinants that affect brain, that gut-brain axis with social support, you may have patients that have very little social support in their lives, or people who help to provide some resilience to their lives and important others who are consistent. So often with those types of situations, you would start with the getting support from others. And this entire activity is much shorter, and it's designed to help people identify a safe, supportive person to help them with their behavior change and help them with their condition. The planning ahead of time is a goal setting, is a much more intensive goal setting walkthrough than you might be used to. We've looked at all of the literature and said, okay, in all of the literature, we think this is the best and most effective way to set goals and help people meet their goals. So this is a series of activities where people establish their core values, how those relate to their goals, and then they identify activities. They use planning tools that are in the app to those days when they're going to practice their goals, like yoga, breathing, mindfulness activities. And then we also have a mindful eating program. And how we designed this program is we looked at all of the research studies on mindful eating. We looked at studies that showed positive effects of mindful practice. And then we looked at, as part of those studies, what were activities that were similar between all of the different interventions in the studies that were successful. And we took those activities and combined them into a 6-week mindful eating program that your patients are also able to use. In terms of the scores that I think Dr. Raman mentioned, patients are provided with scores for physical activity, sitting, screen time, sleep, stress, well-being. They're asked to update these every 6 weeks. You can see here, complete your LyfeMD assessment. That will take me to the survey tool that then helps me update those scores to see if I've made any progress over time. Lastly, I want to show you on this screen is my food list. So remember, as I was doing that low FODMAP program, I completed that food list. It's always available just on the home screen, so people don't even have to go back into the eating plan to get it. Now, another program that I just want to show you here is another part of our app program is they can choose to connect to different weekly programs that we may have. So this program itself is, I'm assuming, Jackie, give me a thumbs up. You can see the yoga for digestive pain screen.
Yes, you can.
Okay, thank you. So this program is designed specifically around IBS and digestive pain. It was designed by Dr. Raman herself, and she, who is a certified yoga nidra instructor as well. And what she put together is a program that includes somatic yoga, which is very small movements, breathing practices, and gut hypnosis. So what patients are able to do is work their way through this program. They have some intro videos they're able to watch, and then they work through this progressive yoga program, similar to the research study that she presented in her talk today. I'm going to stop sharing there, and I'm going to share another screen quickly, because I just want to walk you through how the LyfeMD app works for healthcare practitioners like yourselves. So if you want to test the app and you want to give it a try for yourself, this isn't to be used with patients, but you are able to test it and play around with it and see how it works. So to do that, we've given you here a free subscription code. You can download LyfeMD on the app or Google Play stores. You can also download it on our website, www.lifemd.com or .ca. It doesn't matter. Make sure you spell it with a Y. That's the only thing where people get mixed up. And you can sign up there, and then you are able to you're able to look at the programs and play around with it to figure out how it works. In terms of cost for patients, so we do have a 12-week program that costs $250. And what this program does is when the patient comes into the app, if they've chosen this program, they get an intake completed with them with then a report that is produced. So if you're doing this in partnership with the patient, you can then receive the report. So this report talks about their sleep, their stress, says all of those different factors we measure, their IBS symptom severity score, and it gives you a background on, okay, how is this patient doing on these different parameters? The coach then does a walkthrough of the app, tells people how to use it, where the different programs are located, and gives them some suggestions on the yoga, breathing, mindfulness, or CBT, and some suggestions on where they think that the person could start in terms of some of the mind-body interventions. They then do biweekly check-ins. So you may see a patient, work on them with low FODMAP, say, are you doing the mind-body interventions? Great, you can follow up with your coach and then let me know how you're doing at our next appointment. So the coaches check in, and this also provides the end user with a 1-year subscription to the app. They have access to all of the content, and they also are able to access in-app chat to ask questions of the coaches at any time during this process. In terms of a monthly, so let's say you're working with your patient on low FODMAP, you feel like, okay, I want to maybe use this for a few months. The patient is able to use this at a 60% discount for anyone who's attended this session as a health professional. So we will be providing you with a promo code you can use for any patient that you're working with, so that the cost of the app for the specific time period they want to use it is $15 a month. They can, this will provide them with a 1-year subscription that they're paying monthly for all of the programs in the app. It also provides them with a coach walkthrough. If they choose, they want that service, the coach will help them get signed up, help them know how to navigate and use the app, and then also includes in-app chat or question and answers. So what are some of the next steps? So we want to be able to support you in your practice if you're interested in trying this. We recognize you might want some time to fool around with it to see what you think. So we're going to send out an email link next week where you will have QR codes where you can access either of the programs that are part of the LyfeMD app, and you're able to email those right to your clients so they can sign up and do either of the programs that they're interested in. And we will also at that time provide you with the discount promo code that you can use with your clients specifically to access the app at a greatly reduced cost. So I'm going to stop sharing there, and I think I'm going to turn it back to Jackie to bring up some of the questions that have been asked.
Perfect. Now I am going to pop up the poll here. This is what I'm going to do. So let's just go back. I'm going to launch the questions again. So for those of you who are there, if you've stepped away to stir your pot on the stove, come back, answer your question, and let us know if your confidence in discussing mind-body techniques has changed at all. So let us know what you think. Are you seeing this on your screens just to confirm, okay. I'm going to go here. I'm going to go back here and I'm going to launch it. Oh, okay. Well, maybe while I work through this, we'll just launch into the questions and answers. So let me go through. We have our first question, and it was, and I believe this would be for Dr. Raman. So in your opinion, do you have any data assessing that this specific program included yoga, meditation, and breath work, would be useful only in patients affected by gastrointestinal tract disease as IBS or IBD? Would it also be helpful as a preventative factor to prevent developing GI disease? So wondering if there's any comment on that type of evidence.
So that's a very interesting question. So of course, prevention studies are really hard to do. So you need lots of people, usually hundreds of thousands of people, and you need to follow them for a long period of time when we think of preventing disease. So for lifestyle interventions like this, that study has not been done. So I would say we don't have data to really report formally on the practice of yoga, breathing, or mindfulness and its ability to prevent disease onset. So prevention, I think, is very interesting. I agree. I have an interest there as well, but I think to design a study with that's rigorous enough to be able to look at this would take a lot of effort as well as cost.
Okay. Let's see. There was another question that, okay, so what would be like, oh, how do you encourage your clients to try out mind-body therapies? So wondering about, there's sometimes that scripting that, some of us need a little bit of help along the way of just how do we talk about it with some of our clients who we might think might be a bit resistant. So how would you kind of bring that up with your clients?
Yeah, it's a good question. And, I feel like I always expect more resistance than I actually get in real life. So when I have a patient in front of me and we're going through their history and we collaboratively land on a diagnosis of IBS, and I talk to them a little bit about the brain-gut interactions, we talk about some of the environmental triggers of disease, that it's a nice segue into asking the patient about whether they feel that they have any extra stress or perceived stress in their lives that might be different today compared to a year ago. Have they observed any differences in terms of how their GI symptoms are managed in the face of stress versus not having any stress? I talk to them about their mood and whether they feel their mood has any impact on how they feel and how their abdominal discomfort may play out. And when we have that shared decision-making and that shared collaboration, it's actually an excellent opportunity to create that safe space for people to want to talk about it. And at the end of the day, I find that people are there to have input and to have some direction on interventions they may pursue to overall feel better. So I think sometimes they feel very validated when we bring up these topics, and there's reassurance around the fact that, yeah, IBS kind of is in your head, but not really. So now we understand how these mechanisms may be at play and how directed therapies like hypnotherapy, gut hypnotherapy, general hypnotherapy, CBT, etc., may actually influence the signaling pathways. So I think once you start to share the science, there's a reasonably large buy-in.
Okay, perfect. Now I'm just going to unmute Ruth Harvey because you have your hand up. So thank you, Ruth. Let's see. You just need to unmute yourself if you're ready. There was a hand up, so give Ruth a minute.
Sorry, it was an accident that my hand was up.
Oh,
I appreciated this though. Sorry.
No problem, no problem. Well, we had the chat a little bit locked earlier on, so I wanted to make sure you didn't have a question. let's
So
see.
Jackie, I have a quick question,
Sure.
Dr. Raman. So Dr. Raman, so in terms of medication therapies for IBS, what do you think is there still a role if people are on medications? How effective might they be in resolving some of the symptoms? And then where would you place mind-body interventions into that treatment plan?
Okay, that's a great question, Lori, and thank you. So we didn't really have time today to talk about the different categories of IBS, but IBS is typically divided into 3 categories. So constipation predominant IBS, diarrhea predominant, and mixed. And usually that's defined by constipation happening more than about half of the days, diarrhea happening more than half of the days, and then mixed pattern sort of alternating between diarrhea and constipation. So historically, the medical treatment of IBS has really focused around the symptoms. So if constipation being the most frequent subcategory of IBS. So usually I explain to my patients that it's important to have a treatment that focuses on symptoms, as well as a treatment that focuses on underlying physiology or pathophysiology. So if in the case of constipation predominant IBS, I put them on some pharmacological therapies or medical management, I will explore the underlying sort of role of the brain and potential central factors which may influence their bloating, their cramping, their anxiety. And if I'm able to land on usually about 2/3 of patients are going to have one of those coexistent symptoms. So at that point, I'll put them on their medication, whether that be their Restorelax or their Constella or something else. Plus, I will prescribe a specific yoga, breathing, and mindfulness program. I'll also prescribe even a physical activity program, although the data are definitely very good compared to control groups. So I'll give the patient the option. What is their preference? What do they think they can do? What can they sustain? What's feasible for them? So whether that be a physical activity approach, whether that be a mind-body approach, as long as they're doing something else alongside of their medications, we're likely to achieve better outcomes.
Okay, great. Thank you. I'm going to try one more time to launch this. Hold on. Oh my goodness, I'm so sorry. A bit of a difficulty here because for some reason it's not launching the second question. My apologies. So we may have to stop and not do our second poll. So I hope that was very useful for everyone. Let me just share my screen. Okay. Okay. So I just wanted to thank everyone for attending. I believe that's all of our questions. Let's see. Yeah, that's everyone. But there is in the chat, there is an email, the info@lifemd.com. So if there are some other follow-up questions, and for those of you watching the recording, please feel free to send us any messages, any feedback, and any comments. Stay tuned for the next LyfeMD Learning Series event, and please update your preferences on the LyfeMD communications in order to be on the contact list for future events. And please invite a colleague next time. And don't hesitate to reach out to us if you have any questions. Take the time to complete the survey in the lobby on your way out, and it will also be in the emailed link when you get the recording. You can go back to the lobby in the webinar events and fill out the survey there. And Dr. Raman, you had your hand up?
I did, just very briefly, because I did see a question in the chat around whether patients can access funding to utilize the app. So I wonder if maybe I could turn that question over to Lori and for her thoughts.
Sure.
Sure. So we are working right now with a potential company that makes some IBS medications to cover a certain number of subscriptions for patients every year. So that could rapidly change, and we will let anyone know who is on our mailing list about if that does change. We can access for any patient who has inflammatory bowel disease, so Crohn's or ulcerative colitis. We can cover any patient at all with IBD has a subscription that is already paid for. So anyone with IBD does not have to pay anything if they want to use the LyfeMD app. But because patients, we don't have right now a pharmaceutical sponsor for patients with IBS, they do have a charge for the app, but we are hoping that that will rapidly change. We're working on a number of different companies to provide educational grants. So, as well as some of the pharma companies that make these medications. So we will keep you updated on that if that changes. In terms of anyone who's, part of our email list will be made aware of that.
Okay. Well, thank you everyone for attending, and I will give one more look at the chat to see if we have any more questions before we conclude. And I think that's everyone. Okay, thank you so much, and it's been a great first event. All right, that concludes our night. Bye, everyone.